Hello and welcome to the clinical anatomy of basic life support. My name is Dr. Cobb, and today I'm going to link clinical anatomy with BLS. I want to discuss the best practice for BLS and link this within clinical anatomy. So some of the outcomes I'd like to cover, I'd like to look at the understanding of current legislation and local resuscitation policies, understanding the individual role and responsibilities in responding to persons in emergency situations, clinical recognition of cardiorespiratory arrest, the point of getting immediate help and how that should be done, and recognition and response to patients with clinical deterioration, escalation in care in accordance with local policies or local trust policies. I would like to be able to initiate an appropriate emergency response in accordance with Resuscitation Council guidelines and be able to provide basic airway management instructions and relate this clinically with clinical anatomy for clinicians and clinicians in training, and understand individual responsibilities in reporting and recording details of an emergency event and how to do this accurately, and to trust policies. And of course the application of the DNAR, or the Do Not Attempt Resuscitation policy, within a clinical context. So just some facts and figures for you. Out of hospital cardiac arrest, incidence of sudden cardiac arrest is 0.4 to 1 per 1,000 people. Out of hospital cardiac arrest have very poor survival rates. Survival rate is 2%. This can increase to up to 30% when defibrillation is received in 3 to 5 minutes. And I'm going to talk to you a lot about clinical anatomy and physiology as well, and look at the importance of defibrillation within basic life support, intermediate life support and advanced life support, and really how important it is for defibrillation to play a role within resuscitation, and when it doesn't, physiologically why the outcomes are so poor. In hospital, so if we are talking about hospital environment, usually a predictable event with a clear decline in the patient's condition. So cardiac arrest, things like track and trigger and our scoring, and when we see our patients, a lot of the indicators can show that the eventual cardiac arrest is something that had been previously noted, but of course, we can have sudden acute onsets as well. Survival rate to discharge from hospital is 14%, although this is higher if the cardiac arrest occurs in certain clinical areas such as critical cardiac units and catheter labs, anaesthetic rooms, so areas where not necessarily that the staff are just trained, but also that the equipment is more readily available. I'm going to talk, as well as linking, the clinical anatomy and the clinical physiology. I'm going to link a lot of case studies to this talk as well. And a gentleman called Fabrice Mwamba, who was a football player who actually was successfully resuscitated. I'm going to be linking his story to this presentation. And due to his particular story, we talk about something called the keys to survival. And now the keys to survival, or the chains of survival, really are down to certain key things, and these are the recognition of the deteriorating patient and preventing the actual cardiac arrest, good quality CPR with minimal interruption. Early defibrillation has overwhelming evidence for successful rates, and that really is no wonder when we think of the heart itself. The heart, acting as a pump for the body, has an electrical impulse. Now, when we go into cardiac arrest, of course, this electrical impulse is slowly dissipating to the point where there is no more impulse. So the defibrillator, the very act of defibrillation, is trying to get the electrical impulse to a normal physiological range. So up to 75% survival rates have been reported with prompt defibrillation, and Fabrice Muamba is a classic example of this. Professional football player that during a big football match live on TV started to experience shortness of breath, or SOB. And if we're thinking about these changes of survival, and we look at the first one, the recognition of the deteriorating patient. Now, Fabrice was on playing, a live match, was becoming obviously unwell, then eventually collapsed. Now, it was very fortunate that the medics, I think it was physiotherapists, were the immediate ones to his side. Went to do the basic life support, so started to look for breathing airway or airway breathing circulation, and very early chest compressions were performed, along with early introduction of the defibrillator. So defibrillator was brought on the pitch and attached, and this began very, very quickly within the first couple of minutes of this early recognition of him becoming unwell. So what's the purpose of basic life support? Why am I putting this on my channel? Why is it so important? Well, it's as a clinician myself, and one who has been teaching basic life support, intermediate life support and advanced life support for several years across the UK and the US, it's absolutely vitally important that all understand, not just clinicians but laymen as well, that by doing absolutely nothing, the outcomes are of course, there is no positive outcome. So basic life support is absolutely essential, and it should be made readily available and understandable to all walks. And I hope with this series, with the slides along with my 3D models, where I shall bring to life, as it were, the anatomy and physiology behind basic life support, to make this readily available to general members of the public as well. So the purpose is maintaining an airway patency and support breathing and circulation without the use of equipment other than a protective device. And this is from the UK's Resuscitation Council in 2010. And failure of the circulation for 3 to 4 minutes will lead to irreversible cerebral damage, unless if the victim was initially hypoxic. So we have a very short period of time from the point in which somebody stops breathing. So walking down the street, you see somebody struggling to breathe, maybe having an asthma attack or some kind of respiratory problem, choking, etc., etc. Very, very short period of time from once somebody has stopped breathing to the point where irreversible brain damage has occurred. So let's just quickly look at the Resuscitation Council's guidelines in 2010, talking about maintaining airway patency and supporting breathing and circulation without the use of equipment. So when we're talking about basic life support, we really are talking about basic life support. We're not talking about advanced airway management, where we can have a selection of airways and intubate the patient and get the bag valve going and everything else. We're talking about the very basic physiological process of cardiopulmonary resuscitation, the mimicking of the pumping motion of the heart and the inspiratory and expiratory movements of the lungs, which we do via the purpose of compressions. So the very nature of doing chest compressions is mimicking the cardiopulmonary system by the interthoracic pressure which is produced when we compress upon the chest, which we're going to talk about and look at in this and the subsequent and the following video. The maintenance of the airway is completely dependent upon whether the airway is manageable. In the choking patient, it may very well be that the airway has become blocked, and therefore the only thing that can be done may be to do chest compressions, which in itself can bring interthoracic pressure, which may actually clear the airway, and also, of course, work the cardiopulmonary system by allowing circulation to continue to the brain. I also want to talk about responsibilities, roles and responsibilities. I'm just going to be talking about this from the English point of view. I'm not going to be talking about the United States or teaching basic life support within the USA. I'm just going to talk about it within the UK for this session. Hopefully make you a subsequent video where we can look at the US system and codes of professional conduct. But this is for the UK, codes of professional conduct, legal responsibilities and local policies. And I just want to start with the Nursing and Midwifery Council, the NMC. So this is for registered nurses, adult nurses, paediatric nurses, etc., anyone who has a license with the NMC. So the NMC states that you must be able to demonstrate that you acted in someone's best interest if you have provided care in an emergency, and you must recognise and work within the limits of your competence. So what does that mean? Well, it means that if you're in a supermarket and somebody collapses and you are a registered nurse, and you do begin to go through the process of basic life support, that you really must be able to demonstrate that you have acted in the best interest of the person you're providing care for. So, I mean, obviously, if you have put yourself forward and said, yes, I'm a nurse, I can help in this situation, and then you don't perform any of the stages of basic life support, you really haven't acted in the best interest of the patient who is on the floor, or the potential patient who's become on the floor. And again, that also comes down to working within your limits. If you are competent, do you feel competent? Do you feel that you've attended the correct courses? Have you kept up with your CPD? Continued professional development. Are you recently trained in basic life support? So all of these things are really important to consider for the clinician and licensed clinician. And also, in an emergency situation, in or outside the work setting, you have a professional duty to provide care. You are a healthcare professional. You are trained and educated to a certain level. So you do have a professional duty to provide some level of care. The General Medical Council, the GMC, also in an emergency, wherever it arises, you must offer assistance. So if you are a medical practitioner, in providing care, you must recognise and work within the limits of your own competency. So very similar to that of the NMC, working within your competence levels. With the GMC, in an emergency, wherever it arises, you must offer assistance. Slightly different. You have a professional duty, and you must be able to demonstrate that you have acted in someone's best interest with the NMC. It's kind of a little bit more specific with the GMC, stating that you must, wherever it arises, you must offer assistance. But both professions and both regulatory authorities say that you really must work to try and do the best to help the patient. Health and care professionals or professions council, you must act in the best interest of service users. Your professional knowledge and skills should be up to date, and you must act within the limits of your own knowledge and skills. So very, very similar again to that of the NMC and the GMC. Registrants are required to take up a reasoned and informed judgment about the most appropriate course of action. So, of course, if you haven't ever done a CPR course and you have little to no knowledge, then it's probably best that you don't get involved, because you may actually do more damage than good, Legal responsibility. So, as I say, I'm just talking about the UK today. In the United Kingdom, there is generally no legal obligation on a perverse person to provide care or assistance in an emergency situation. In essence, there is generally no legal liability for an omission to act. However, there are a limited number of relationships where courts in the United Kingdom have found that a positive duty of care exists. One relationship is that which exists between a healthcare professional and the person they are responsible for providing care for. So in a hospital setting, if you have a patient that's going into cardiac arrest and you do absolutely nothing about it, you are kind of looking at some legal ramifications there. Legally, healthcare professionals are required to act if they have an existing professional relationship with the injured person, or have caused the situation which created the risk and resulted in the injury to the person itself. So if you've actually caused this situation by maybe giving the wrong medications, or you've actually caused some of these issues yourself. DNAR, do not attempt resuscitation. This is where a decision has been made not to attempt cardiopulmonary resuscitation. It in hospital settings is effectively recorded in the patient's notes. And certainly this is something that changes between trust to trust. I worked in a very big trust in the UK, and then I actually worked in several emergency departments across the UK, and they do have different coloured DNAR forms, so it's just really being aware of what kind of form and what colour form that you have in your trust. But it should be noted that obviously in the basic life support out in the public sector, slightly different. It's unlikely that you're going to find a key chain pendant around the neck saying do not resuscitate, and you may well have somebody screaming at you saying he's not for resuscitation, but without clear evidence it's difficult to make that conclusion. Effective communication on the decision with all healthcare workers and organisations should be involved along with that of the patient. So, I mean, the DNAR, the do not attempt resuscitation itself, is something that the clinician will have discussed with the patient and looked at how effective resuscitation would be in their particular case. So certainly with people who have terminal illnesses or the prognosis is poor of chances of survival post-resuscitation or during resuscitation, then these are things that will be looked at. Record keeping, this is certainly more for in-hospital, so obviously this is an event that certainly needs to be recorded. Often this is not a priority at the time, and the quality of record is variable. So unless you're actually working in a resuscitation department like I did myself, where you might have a scribe who is keeping track of this, the priority is, of course, to get on with working on the patient. Complete trust documentation as per local policy. So different trusts will have slightly different ways of recording this. And it may vary. Often there may be 2 records needed to complete, but patient records within trusts vary greatly. So I don't want to go into that too much. But what I really want to start to do is to talk about the nitty-gritty of the actual ABCs of basic life support, BLS, basic life support, ABCs. So what we can see here, we can see an observation chart. This is very, very classic observation chart seen in many hospitals across the UK, the track and trigger chart. And as many of you who are hopefully watching this who are clinicians who are just looking at doing a little review for your basic life support, for your CPDs, or just getting you back into practice, or you're in practice and just just doing your basic annual update, you will remember that the track and trigger is an early warning system. where one can view over time potential triggers that may lead to a cardiopulmonary event or respiratory event, which might lead to a cardiac event, which of course then may need CPR. I'm not going to be covering those too much today. I'm really going to be talking about the basics. So I want to just kind of go back again to my earlier story about Patrick Mwamba and the chains of survivals and kind of his story and how he survived through these chains. So these chains of survival really work with the story of Patrick Mwamba, our professional football player. And if we just jump back a little bit earlier to the story I was telling you about, this young man was playing football live on TV, started to have breathing difficulties, clutching of the chest, early recognition being, there's thousands or hundreds of thousands of people watching this happen live on TV, as well as the game side medics. Early CPR was performed, as soon as he had got to the point where he was holding his chest and then collapsed. People are all around him, chest compressions beginning. The defibrillator was attached very quickly, and he was then sent to a hospital for post-resuscitation care, and then of course he successfully came through this. So he'd gone through the entire chain, all of the chains, and came out the other survival. He's a big advocate for the BLS and talking about BLS and really getting people to understand the importance of just understanding early recognition, early chest compression, early defibrillation equals good outcome. Non-early recognition or non-early CPR, or certainly without the defibrillation as well, the chances are survival are greatly reduced. And of course, as you remember, 2 to 3 minutes without oxygen, and the brain, really starting to get lots of neurological damage. So it's really important that these chains of survival are remembered within BLS. So early recognition, early chest compression, early defibrillation equals good resuscitation outcomes. So let's just talk about safety for oneself. One should always be ensured of the safety of the rescuer and the victim before approaching. So basic life support, it is anywhere. We could be talking about anywhere. We could be talking, you're driving home from school one day and you see a car accident, or you see somebody hit by a car and they're lying out in the middle of the road. Are you just going to step out and into the traffic and become a victim yourself? Well, people do. There have been many cases where people have become victims they've gone out to try and help, but they've actually unfortunately become victims themselves. So it's really important that safety is a number one. Am I safe? Are you on the underground, the tube underground? Somebody slips onto the lines and they're electrified. You go down there, you're going to be electrified yourself. Is somebody just in a small body of water and there's an electric cable poking in the water, and by you stepping in you're going to get hit yourself? So there's all kinds of factors that play into traffic, electricity, gas, water, fire, chemicals, people pretending to be down so you go and aid and then become a victim yourself of crime. Work environment, there's lots and lots of environmental factors that one must be aware of. Infections associated with mouth-to-mouth, there's no case reports of HIV, hepatitis B, C, or anything such as that being reported. 15 infections have been associated with mouth-to-mouth, which include TB, meningitis, herpes, simplex, gastrointestinal pathogens, etc. Now, the thing is with the mouth-to-mouth, some people carry around a face mask, basic life support face mask, what the up-to-date research, and I really want to emphasize this for you all. The reason I put these videos on here is I've tried and get as much research and up-to-date resuscitation guidelines as possible. If the airway is unmanageable, for instance, in trauma or vomitus or etc., the compressions alone, continual compressions alone, have been shown to the interthoracic pressure, which is driving the cardiopulmonary system and is mimicking the rhythmical beating of the heart, and pumping blood to the brain, most vitally the brain, and of course the expiration and inspiration of the lungs during the compression is adequate within BLS. Infections associated with contact transmissions, 3 case reports of HIV, all involve heavy contamination of broken skin from blood from patients with HIV, and Group A streptococci secretions from a child came in contact with a firefighter's abrasion, and the firefighter became acutely unwell with streptococcus pathogens. Now, again, we're talking about a very small amount of cases when you think about the much broader picture of the amount of BLS, ILS and ALS that goes on across the country. Moving and handling, being aware of your own strength and build in relation to patient built weight and build, and looking after yourself. So really making sure, kind of going back to the very beginning, it's all about safety. If you put yourself at risk, you're putting your patient at risk as well, or your potential patient at risk, because if you become injured, who is going to be able to save them? Checking for response, shake and shout. So once you are safe to approach, it's important to do, or there's the doctor's ABC, there's the danger response, airway, breathing and circulation. So once we know that the area is safe, the D's out the way, we need to see if the patient, is somebody just lying down having a sleep. I remember one day I was going to hospital to work in the emergency department. As I walked to work, there was a man lying by the roadside, and I thought, oh my goodness. So I looked across the road and it was safe, and as I started walking towards him, I could see that he had been drinking. There was some alcohol by his side, and to cut a long story short, he was just inebriated and unconscious, and I got him into the recovery position, and he eventually came round, and he was fine. But so the shake and shout, we shake gently the shoulders, so it's not really a shake as such, it's just like a gentle squeeze of the trapezius muscles, gentle touching around that area, and then trying to speak into both ears to see if the patient's okay. Are you alright? Can you hear me? Are you okay, sir? Are you okay, ma'am? And the reason it's in both ears is, again, to make sure that the communication's getting through. Somebody might have hearing loss in one ear, they might be deaf in both ears, so we're doing a tactile and a verbal response. So what do we do if there is no response? Well, we need to get help. We need to get help immediately. So we can shout for help, we can call 999. This is our opportunity to, you could dial 999 now, or just shout for help. Help, there's somebody down here, I need some assistance. And really there's 2 points in which you can call the emergency services. There's the point before which you start chest compressions, because of course once you start chest compressions you can't stop. You need to keep going until either you can't continue or somebody else helps you. So the assessment, the doctor's ABC. So we've done the danger, the response. Now we're going to look at the airway, breathing and circulation. Airway. What are we looking for in the airway? So a very, very quick basic life support airway is to just examine the mouth. It's to open the mouth just with the fingers, just to look inside the mouth. The clearing of debris, if there is something that is just on the lips that you can move, wonderful, then do so. But if there's anything further down, it is not advisable to put your fingers or anything in the mouth at all, because if the patient was to bite down, they're going to bite down on your fingers, or if there's anything in the airway, you might push it down and then actually cause a further airway obstruction. The open head with the airway with the head tilt and chin lift. So if the airway is clear and we can tilt the head back, we want to look, listen and feel, or LLF. This is where we're going to put our ear and our head down to their airway about an inch or an inch and a half away. Well, with the forearm on the forehead, so when we do the head tilt chin lift, we just gently push the head backwards with our hand on the forehead, on the patient's forehead, and we can LLL, look, listen, feel, LLF. And we want to keep the airway open. We want to access for breathing by looking for the chest movement, listening at the victim's mouth breath sounds, and feeling for air on the cheek. So this is really, really important. And this is for everyone. This is for the layman as well as the clinician. Of course, clinicians are going to have much more experience of coming into contact with resuscitation than those who have no medical training at all. But the principle is very basic, and it's just looking, keeping the airway open, listening for breathing, look, listen, feel. Is there any movement of the chest? Can you feel any air on your ear or on your cheek? And listening for any sounds or any breath sounds. So signs of life. When you're looking, listening and feeling for breathing, also assess for signs of life. Is there any movement? Are the eyes opening? Is there any coughing? Carotid pulses, etc. Really don't need to worry about that for basic life support. It's much more for in-hospital, and pulses we're not going to be talking about today. We're really just looking for any basic signs. Is there any breathing? So, if there is no breathing, there's no sign of life, we've waited 10 seconds, 5 to 10 seconds, and there's no sign of life. When the victim is not breathing, or is there agonal breathing, so minimal breathing, what we really, really need to do is we need to get an AED. The AED is the thing that's going to change, it's the game changer. It's the thing that's going to get that electrical impulse working again. So if you are in the community, if you are out on the street, in England you call 999. 999 to get the emergency services, and you explain what's been happening. I've walked along, I've seen a gentleman collapsed on the floor, I've approached, I'm checking his airway, there doesn't appear to be any breathing. I really need to get the paramedics here with the AED, and I'm going to commence resuscitation. I'm going to start with chest compressions, and my location it's really, really important to get the location so they know where you are. And if this means leaving the victim to get help, you must do so. So if you are out in the middle of the country and there's nobody around, there's no cell service, really the best thing to do is to try and get some help, because you may be out there and become a victim yourself. You might become hypothermic or hyperthermic, depending on where you are. If you're out in the middle of the desert on your own, and you're going to become dehydrated pretty quickly. So if you have a cell phone, most people have a cell phone, call 999. And if you have a cell service, then wonderful. If you don't, then the best thing may be to try and get help. So compressions, what do we do if no breathing? Well, we're going to start compressions. And we're going to try and position the hands in the center of the chest, And this is something that I'm going to talk to you. I'm going to drag up one of my 3D models for the next video and talk about chest compressions and intrathoracic pressure. So we want to get the sternum 5 to 7 centimeters depression and a rate of 100 to 120 compressions a minute for 30 compressions. So in basic life support, the cycle is 30 compressions to 2 breaths. If the breaths can't be done, it is continual compressions. So it's just on and on and on until either you cannot continue or the emergency services arrives or somebody takes over for you. So we want to position position hands in the center of the chest, and I'm going to put on some external links for you so you can watch some videos of resuscitation and the rhythm, the rate and the depth when you go and do your training courses, because remember, this is not a training course, this is just a discussion of the clinical anatomy, going through basic life support, and hopefully just recapping on some things that you may not have been aware of. The rate 100 to 120 beats per BPM. Nelly the Elephant Went to Town is one of the songs I know that I've also heard. Staying Alive by the Bee Gees. So there's lots of different ones that you can use. Myself, I just prefer the counting 1, 2, 3, 4, 5. Continual effective compressions are so important. They're so important, and I'm going to link this with the clinical anatomy on the next video, so we can really have a look at why compressing the sternum makes such a difference. Ventilation, as I said, the starting of the rescue breaths is very dependent. I mean, if this is out in the open and you can't manage the airway, or you don't want to manage the airway because the patient's mouth is covered in blood or vomitus, then we really are just going to be considering these compressions. Compressions are so important, because without the chest compressions there is no interthoracic pressure, there is no cardiac movement or pulmonary movement at all. There's no inspiratory or expiratory going on with the lungs or the heart. We've got nothing going on. So it's absolutely vital that the compressions get going. Now for ventilation, this very much changes depending on where you are. If you're in a hospital, of course oxygen can be attached, and bag valve masks and everything else, and then the 30-2 cycle can be much more effectively managed. So here I have just a little image for you that's going to relate to my 3D anatomical model, which I'm going to go through. So what you can see here is the sternum. This is a cross section through. We have the diaphragm, and of course here's the heart sitting on the diaphragm, so the diaphragm kind of forming the floor, and of course the sternum in the front, the different parts of the sternum. You've got the manubrium, the body of the sternum, the xiphoid process. I'm going to go into the clinical anatomy much more, but essentially, in very basic layman's terms, by compressing on the chest, on the central part of the chest, on the sternum, what you're doing is the force that's coming in is compressing on the heart, mimicking the rhythmical motion of the heart. But also what it's doing is, because you have the lungs each side of the heart as well, it's also mimicking that inspiratory and expiratory reserve volume which you get during respiration. So this interthoracic pressure, so the pressure that's built up in this interthoracic region via chest compressions, is effectively mimicking the physiological function of the heart and lungs, and hence the reason it's called cardiopulmonary resuscitation. It's artificially mimicking that very thing. So when do we stop? When is enough enough? Well, if the victim starts to show signs of recovery, waking up, coughing, opening eyes and moving, or starts to breathe normally, or if there's any kind of signs of breathing, we can roll the patient over into the recovery position and monitor them. And again, if they then stop breathing, you go back into chest compressions. Expert help can take over, so once the paramedics arrive, the 999 team arrives, or the crash team from the hospital arrives, they can take over from you. Exhaustion. So if you can't physically possibly keep going, then obviously you won't be able to keep pumping away on the heart and on the lungs. Or if the situation has become unsafe, so if your own life is now in danger. So just kind of going back to what I said a moment ago, chest compression only CPR may be as effective as combined chest compression ventilation in the first few minutes after non-asphyxial cardiac arrest. CPR with ventilation is the method of choice. So obviously if we can do the ventilations, then great. If not, then the chest compressions alone are effective. Lay rescuers who are unable or unwilling to provide rescue vests should be encouraged to give chest compressions only. So that again, just reiterating what I've already said, laymen who may be unwilling to manage the airway can just manage the chest compressions. Variations: 2 persons technique. Rescuers work from opposite sides of the victim. Compressions commence immediately following a second breath in. So this is very much to do with when there's 2 people or more people who are available in the scenario. Now this is really, really important. This is an important point because for instance, if you are down on the ground and you're doing effective chest compressions and you're getting to the point where, okay, I need to swap, communicating with a second person or third person or fourth person, okay, can you take over chest compressions on me on 30, 28, 29, 30, swap. So it's really, really important in CPR to have really, really effective communication between teams. So it's just about maintaining that communication even during the airway, even during the event itself. Airway adjuncts. I'm not going to talk hugely about these. Some people carry around face shields to prevent contamination, blood or saliva. Pocket masks and bag valve masks or BVMs, much more common in hospitals and out of hospital settings, ambulances, etc. So really, really dependent on where you are, whether or not you're going to have access to these things. Again, a little bit more about airway adjuncts, which I don't want to go into too much today. Oral pharyngeal airways, the different types of size, and just knowing, of course, that the correct size is absolutely paramount. So if you have skills in airway management, then of course you're going to be very aware of the different sizing. But during your training, airway adjuncts will be covered, and they'll show you when you do your resuscitation training on the mannequin how to adequately assess for sizing. And nasopharyngeal airways, there are contraindications, so this in trauma such as basoskull fractures. The nasopharyngeal airway is not a good choice in basoskull, because obviously this could then be introduced into the base of the skull and into the brain as well. So these airway adjuncts are all things that you will be able to practice with during your